Hello. Good morning, everybody. I am from Bardhaman Medical College. My lecture will be on drug-resistant TB in children. Before going into the details, we should know some basic aspects of drug-resistant TB. And it is seen that most of the cases of DRTB occurs in children following exposure to adult having DRTB. And it is also seen that DRTB in children is more common, where DRTB in adult prevalence, incidence and mortality of DRTB adult is high. In that places, DRTB in children is common. And less often, DRTB in children occurs following exposure to patients with improper TB treatment. And according to recent guideline of NTEP, we know microbiological confirmation is must, but it is very difficult to get microbiological confirmation in children. So, children having TB with history of exposure to adult having DRTB, we should suspect those cases as having DRTB. Another common fact is that extrapulmonary tuberculosis incidence is more in children in comparison to adult, and in case of extrapulmonary TB, it is very difficult to get the microbiological confirmation. So, we should know some definitions. Monoresistance means resistance to any first-line drug other than rifampicin. That is called monoresistance. Then MDR-TB means resistant to at least HRR, means INH and rifampicin. And at the same time, we should remember that rifampicin resistance, if we get in children, that children should also be considered as having MDR-TB. That means that children should be treated in the line of MDR-TB. Polyresistance means resistance to two or more first-line drugs, but not INH and rifampicin at the same time. Then pre-XDR, resistance to HRR, that means MDR-TB plus resistance against fluoroquinolone or remember this point, or second-line injectable drugs. And lastly, XDR-TB means MDR-TB or RR-TB plus fluoroquinolone resistance plus any one or more than one group A drugs, that means bedaquiline and linezolid and levofloxacin. Those cases should be considered as XDR-TB. And some more terms or definitions. Extensive TB disease. We should know, because management of extensive TB disease in children is very difficult, and majority of them will have drug-resistant TB. So we should know the definition. Refers to pains of bilateral cavitary disease or extensive parenchymal damage, destruction in X-ray. And another term, severe extrapulmonary TB. Severe extrapulmonary TB. We know that most of the cases of extrapulmonary TB are severe, except mild pleural effusion, because we know most of the cases this mild pleural effusion is because of some allergic phenomenon and isolated solitary lymph nodes. That lymph nodes may also be in the mediastinum, but that lymph node should be non-compressing. That means not producing any compression of the mediastinal structure. Barring these few situations or few conditions, all extrapulmonary tuberculosis are considered as severe. Now, presumed DRTB cases, when we should suspect that these children may have DRTB. The first, non or poor response to first line drugs. That means patients on ATD, there is no or poor response and there is no comorbidity. There should be no comorbidity. Then treatment after loss to follow-up. That means drug defaulter. Here patients should receive treatment for more than 1 month. Then there is a loss to follow-up, but again has become microbiologically confirmed TB. And recurrent TB, that means patient treated with ATD, patient cured, again there is symptoms and signs, and on investigation there is microbiological confirmation. So that is recurrent TB or relapse TB, and in these cases, in these three situations, chance of having DRTB in children is more high. Now others, few others, means contact with MDR patients, and that I have told already, child living with HIV, and that is TB death in the family without any having confirmed diagnosis. In those situations also, we should consider that children may have DRTB. But the strategy is changed now. Every patient of TB should be tested for DRTB upfront. That is called UDST. That means Universal Drug Sensitivity Testing. Here, point is that even the previously mentioned 4 criteria are absent. Few treatment-naive rifampicin resistance cases may also be reported. So all cases of TB, irrespective of their history, should be tested for sensitivity, and that is called UDST. So now, approach to diagnosis of MDR-TB in children. First, careful history. History of contact with MDR-TB is very critical, very crucial. Then failing first-line drug therapy. In spite of getting ATD, patient is not improving or rather deteriorating. We have to confirm that from the history, clinical examination, whether there is any lymph node enlargement, there is any pleural effusion, there is any pneumothorax, mediastinal shifting, liver spleen enlargement, all ascites, all features should be tested. That means every organ, and we know every organ of our body may be affected by TB, and that is more so in children, may have from meningitis to ascites. Then HIV testing is must. Even if patient is improving, HIV testing is must. And microbiological confirmation and drug susceptibility testing is paramount and should always be attempted. But problem is that in children, most of the situations we fail to demonstrate microbiological organism. And another point, this point I have already discussed, UDST. With this upfront testing, we may diagnose some cases of rifampicin resistance who are not at all received any treatment. And district and nodal TB, DRTB centers should be involved. Otherwise, it is very difficult to stop the spread. So now, recommended test for drug resistance in TB and their lab turnaround time. And we know in the, that NAT means nucleic acid amplification test. It is called more popularly known as CBNAT. And there are two types, gene expert and true NAT. And with this we can demonstrate organism and also resistance against rifampicin within 2 hours. Merely 2 hours is required to diagnose and also to see the resistance against rifampicin. Then first line LPA. LPA means line probe assay. And we have to remember, line probe assay will be positive only if the patient is MER positive or we have taken sample from the culture isolate. So, smear positivity and culture isolation is must before doing first line LPA or second line LPA. Then intermediate turnaround time, MGIT plus LPA DST means microbacterial growth indicator tube. With this we have done culture, then we have taken sample, and on that sample we are doing LPA DST. It will take 14 to 40 days, and longer turnaround time is phenotypic DST, MGIT and phenotypic DST. It will take 42 days, and it may be more. And there is a difference between genotypic testing and phenotypic testing. Phenotypic testing means we are growing the organism in a culture media, mostly solid. And on that growth of colony we are adding ATD, then we are assessing the inhibition zone. And depending upon that inhibition zone, we are assessing the sensitivity pattern. Nowadays, this phenotypic testing is rarely done because most of the cases we are doing this by genotypic testing, like INHA, RO, CATG, all are that. Those things I am coming later on. So, usually we need both NAT and MGIT LPA DST. As direct LPA DST is only possible if the patient is smear positive. That I have told already. So, few points about line probe assay. Line probe assay means another name is Hen's test. This is nothing but a multiplex DST, a multiplex NAT, can be used in smear positive or culture isolate. And this is the first and only WHO recommended method to see the resistance against other drugs, because by NAT we can demonstrate only resistance against rifampicin. But sensitivity with other drugs can only be done by LPA. That may be first line, that may be second line, that may be LCDST. And there are two types. First line, it detects resistance against ionized rifampicin, and second line, which detects fluoroquinolone, and second line injections, amikacin or kanamycin, capromycin, like that. So both tests to be done to see the resistance pattern against these four drugs. And there is another test, that is LCDST, that means liquid culture DST, which tests resistance against moxifloxacin, linezolid, and other drugs. So LPA produces results in 48 to 72 hours, depending upon the batching. So with this, we see there is a vast improvement against the previous 2 months time taken for testing sensitivity pattern by phenotyping. So genotypic testing is most crucial to detect the resistance pattern very early, as I have told. So now, this is the most vital part. So see, pediatric drug resistance algorithm. So first and foremost we should do NAT or MGIT culture. Here we can get two types. That organism may be rifampicin resistant or may be rifampicin sensitive. So if we get it is a rifampicin resistant TB, we will go for first line LPA and second line LPA. By second line LPA we can say that fluoroquinolone or second line drugs are sensitive or resistant. And by first line LPA we can detect the further resistance against ionized present or not, because by NAT we have already demonstrated rifampicin resistance. So if that organism is sensitive, rifampicin sensitive TB, we can do only first line LPA to demonstrate H resistance present or H sensitive. If H resistance present, that means INHA and or CATG or ethionamide resistance by INHA mutation, then we will go for reflex testing as I was telling previously. By reflex testing in LCDST, we can demonstrate resistance against moxifloxacin, pyrazinamide, linezolid and clofazimine. And if H sensitive, then no problem. So that organism is sensitive against rifampicin by NAT and by first line LPA INH. So by NAT and first line LPA, we can say that the organism is sensitive against both rifampicin and INH. Another important thing is that, as I was telling, it is very difficult to get sample in pediatric patient. Even if we do induced sputum, bronchoalveolar lavage, ascitic fluid, CSF, all these things. In spite of that, very difficult to get the isolate. In these cases, we can take sample from the contact person. Means the source where from possibly the children has acquired the organism. We can take sample of that adult and that will be easy for us. So first line LPA may be done directly if smear positive. It will send for MGIT followed by first line LPA to evaluate rifampicin and INH, as I was told already. Similarly, second line LPA, if smear positive, straight away we can go for second line LPA, or if smear negative, we can do MGIT, then we can do LPA, again second line LPA to see resistance against fluoroquinolone and second line injections. Another point, if there is any discordance on LPA for RRTB, repeat NAT, suppose first NAT was done and LPA done. If there is a discordance between these two test results, we can repeat another NAT at LPA lab. First NAT was done at NAT site, second LPA to be done CDST lab. So, probable MDR TB cases. Clinically, exposure to MDR TB or RRTB case with history of recent death in the family due to TB and or close contact with a person who failed TB treatment, children who were earlier lost to follow-up and where microbiological tests are negative for MTB, or there is no possibility, there is not possible to assess the or get the specimen. So these 3 points, along with there will be history of deterioration despite adherence to ATD by the end of 4 weeks. So there will be history of deterioration or no response following 4 months or 4 weeks therapy, along with any one of these points is significant. So another point, in view of the prolonged duration and risk of second line drug therapy, decision in such situations should be made on recommendation from DRTB committee after ruling out other differential diagnosis. Because most of the drugs we are going to prescribe in these children is very toxic, and if for a prolonged period, all these things can cause serious adverse effect in children. So we have to be doubly sure before administering any drugs for DRTB. So this is the most important table. Integrated DRTB diagnosis and treatment algorithm. So in this, if we follow this table, we will get 3 points, 3 group of persons. In one group we can take all TB patients, another group we can take non-responders, and another group we can take all presumptive TB or key population. So all these cases will be subjected to NAT. Subjected to NAT. So, sorry, there are some technical error. So all these three groups will be subjected to NAT testing. And in this NAT testing, we can get rifampicin resistant or rifampicin sensitive. And first specimen to be tested at NAT site, as I have already mentioned. So if we get rifampicin resistance, then we will do further test to see the situations of other drugs. That means first line LPA, second line LPA, LPDS, LCDST for pyrazinamide, bedaquiline, clofazimine, moxifloxacin, linezolid and delaminid. And in the meantime, before we get the result, we can do the pre-treatment evaluation and we can check the Nixoid app, or we must have some talk with CDST lab. So following this, after the result available to us, we decide in three ways. First, suppose there is no resistance against other drugs barring rifampicin, and other exclusion criteria for SOTR regimen are absent. So in this group, we will advise SOTR oral bedaquiline regime for MDR RRTB regime. And if other exclusion criteria for SOTR regimen is present, then we will go for longer oral M XDR TB regimen. I am coming these two, what is longer and SOTR. But if we get resistance, any resistance against any group like H resistance detected with both CATG and INHA mutation or fluoroquinolone resistance, we will go for longer oral MXDR TB regimen. But if in CDST lab we get the result which shows there is no additional resistance detected or H resistance detected, either CATG or INHA, not both. So in this case, we can go for SOTR bedaquiline containing regimen. So we have started longer oral, either longer oral or SOTR oral. In the meantime, if additional resistance or intolerance or non-availability of any drug or emergence of exclusion criteria appears, we can modify the regimen as per replacement table. Now you see the other limb, rifampicin resistance not detected. Straightaway we will start drug sensitive TB regimen. And we will do second specimen tested for first line LPA. In this first line LPA, if H resistance is detected, we will stop the regimen we have started already for drug sensitive TB, and we will do reflex testing for second line LPA plus LCDST for moxifloxacin, pyrazinamide, linezolid and clofazimine. So if H resistance detected, we will start H mono or poly-DRTB regimen. And if additional resistance, intolerance, non-availability or exclusion criteria, because we have also done reflex testing for second line LPA and LCDST. In these cases, we will again modify the regimen. That I am coming later on. So now, if we consider this group MDR or RRTB, MDR or RRTB, and the case is pulmonary case except extensive disease or non-severe extrapulmonary TB. In these cases, we will start SOTR oral DRTB regimen. SOTR oral means 9 to 11 months. There is a intensive phase and there is a consolidation phase. In the intensive phase, which will be for 4 to 6 months, containing levofloxacin, clofazimine, pyrazinamide, ethambutol, high dose INH, ethionamide and bedaquiline. And next 5 months, we will delete last three drugs, and continue levofloxacin, clofazimine, pyrazinamide and ethambutol. Again, we know, in 5 years or below, we can't give bedaquiline. So, there will be some alteration. Here, what we will do? We will stop bedaquiline and we will start kanamycin or amikacin, and high dose and also levofloxacin will be changed to moxifloxacin high dose. But total regimen will be for 9 to 11 months. Disseminated extensive pulmonary or severe extrapulmonary or PXDR. In these cases, longer oral MDR or XDR regimen. It is, you see, it is for 18 to 20 months, and there is no intensive phase or continuation phase. These 5 drugs will be given at a stretch for 18 to 20 months. There will be no change. Again, if the age is less than 5 years or below, it needs modification. Bedaquiline need to be replaced with 2 group C drugs. We know group C drugs contains 7 drugs. From those 7 drugs, we have to take 2 drugs for bedaquiline. And INH mono or poly-TB, here 6 months, very simple, 6 months, levofloxacin, rifampicin, ethambutol and pyrazinamide. Only INH is replaced by levofloxacin, and it will be continuous, no induction or continuous, it will be given 6 months at a stretch. So no pre-treatment evaluation for MDR TB or RTB is must, because we are going to start very toxic drug for a prolonged period, so should be assessed thoroughly, like complete blood count, random blood sugar, HIV testing, blood urea and creatinine, serum creatinine, liver function, electrolytes, especially for new drugs, serum protein, albumin, globulin, total proteins, and only if delamanine is given, TSH, audiometry, only if we are going to give amikacin and kanamycin, urine examination, routine and microscopic, psychiatric evaluation if required, because we know there are many drugs which produces suicidal tendency. So, before getting cure, patient may commit suicide. Psychiatric evaluation, then ECG is very much important if we want to give bedaquiline, moxifloxacin, clofazimine and delamanid. Ophthalmologist opinion is also very much essential, and surgical evaluation at times it is required but very rarely. So, few points considering for newer and repurposed drugs in children. Bedaquiline can be given to children above 5 years of age and weighing at least 15 kg, and delamanid approved 6 years onwards. Extension of bedaquiline beyond 6 months, and sometimes combination of bedaquiline and delamanid is required at times depending upon the situation. And for children under 5 years of age where neither bedaquiline nor delamanid is approved, yet the longer oral MXDR regimen suitably modified as the replacement drug available. For longer oral MXDR regimen, replacement group C drugs and sequence recommended would be these are the group C drugs. So, if we want to change drugs, and if you want to take drugs from the group C, and that to be done by following a sequence. Sequence is like that: first delamanid, then amikacin, then pyrazinamide, then ethionamide, then PAS, then ethambutol. And our aim will be to avoid injectable antitubercular as far as possible, because most are ototoxic, and if there is some ototoxicity, that will profoundly impair language development of the children. And these are the drugs. So only 2 drugs which can be given in high dose, like INH 15 to 20 milligram per kg and moxifloxacin 10 to 15 milligram per kg. And bedaquiline again we have to remember 200 milligram daily for 2 weeks, then 100 milligram thrice weekly for 22 weeks. And delaminid again 50 milligram twice daily for 24 weeks in 6 to 11 years, and 100 milligram twice daily for 24 weeks for 12 to 17 years of age. And doses of kanamycin, amikacin, capromycin is same, 15 to 20 milligram per kg. And meropenem. Meropenem is preferred in children in imipenem cilastatin group. 20 to 40 milligram per kg intravenous every 8 hours it should be given. And now we should remember these weight bands. Weight bands. Suppose weight band is very much important. High dose INH. Children formulation state is 100 milligram. Adult 300 milligram. In this way, doses are given. And now age 4 to 7 kg weight, 7 to 7 kg, 8 to 11, 12 to 15, 16 to 24, 25 to 29 and 30 to 39. Suppose weight of a children is 8 to 11 kg. So what should be the formulation? It will be 1.5 C. That means 150 milligram of INH, 150. That means one full dose and another half children dose. Suppose another you take 30 to 39, two adult formulation, 2 adult tablet. That means 2 into 300, 600 milligram. In this way, doses are calculated. Suppose clofazimine. If I take clofazimine and weight is 30 to 39, it will be 1A plus 1C, one adult plus one children dose. In this way, doses are calculated, and it is very simple. And one point we have to remember, because we know along with the treatment with ATD, weight of the children will increase. Immediately a children has crossed one weight band to another weight band. Immediately we have to change the drug. Otherwise, the patient will be exposed to lower drugs. And we should remember at the same time few adverse effects also. QT prolongation, very common in bedaquiline, fluoroquinolone and clofazimine. Rash, all drugs can produce rash. Gastrointestinal symptom, ethionamide, pyrazinamide, ethambutol, bedaquiline, clofazimine, fluoroquinolone, INH. Diarrhea and flatulence, ethionamide. Hepatitis, we have to remember because most of the drugs can cause hepatitis and we have to modify the regimen. Pyrazinamide, INH, ethionamide and bedaquiline. Giddiness, ethionamide, fluoroquinolone, pyrazinamide. Hypothyroidism, ethionamide. These to be remembered very well. Aphthalmia, pyrazinamide, fluoroquinolone, bedaquiline. Peripheral neuropathy is very common following use of INH, fluoroquinolone, rarely ethionamide and ethambutol. Headache, very common following exposure to bedaquiline. Depression, fluoroquinolone, INH and ethionamide. Psychotic symptoms, as I already told, may occur following exposure to or following intake of INH and fluoroquinolone. Suicidal ideation, INH and ethionamide is also not rare. Seizures, INH and fluoroquinolone. Tendinitis and tendon rupture, very not frequent but may occur after prolonged use of fluoroquinolone. Vestibular toxicity like tinnitus and dizziness may happen following exposure to fluoroquinolone, INH and ethionamide. Optic neuritis, this test to be done very regularly may happen following ethambutol, we know, age-old drug. Linezolid, ethionamide, clofazimine and INH also cause optic neuritis. Metallic test, ethionamide and fluoroquinolone. Gynecomastia may happen with ethionamide. Alopecia, INH and ethionamide. Superficial fungal infection following prolonged use of fluoroquinolone. And dysglycemia and hyperglycemia may occur following ethionamide. So, from this table it is seen that ethionamide is the most toxic and bedaquiline is also very much toxic. We have to remember all these points before starting, and we have to monitor regularly, and we have to diagnose as early as possible, because once the side effects is very severe, only then if we interfere, result may not be satisfactory. Thank you.